Good evening. Good morning, everyone. I'm thrilled to be here today. My name is Laura Messineo, and I'm the Chief Nursing Officer at Worldwide Health Staff Solutions. And we thought it would be really great to have a quick Q&A in order to address any sort of clinical questions that you might have about practicing as a nurse in the United States. I hope that this is going to be extremely valuable for you. My background is I've been a registered nurse for about 33 years in the United States. And I spent the majority of my career when I was at the bedside in intensive care units and cath labs. But I'm thrilled to be here today. And part of my role here at Worldwide is to enhance the transition of international nurses to U.S. practice. So I'm here to answer any and all of your questions. If everybody wants to put in the chat where they're from, I'd love to see who we have here. So there are some common things in the U.S. from a clinical practice. Welcome from the U.K. We really have patient-centered care, where as a nurse, when we're practicing in the U.S., we really become an advocate for that patient and also that family. We provide holistic care to our patients. And a big part of that is that we also have team-based care in the United States. So what I mean by team-based care is that when we're practicing as a nurse at the bedside in the U.S., we become part of the clinical team, and that might be physician is at the table with us, a nutritionist, pharmacist, and we're all working together to enhance the patient care that we're providing. And everybody is at the table and has a voice. So as a nurse, if I'm concerned about something that's happening with my patient, I can express that concern to the physician, and then there might be a pharmacist, there might be a nutritionist that's standing there too, and they might verbalize their concerns. And together, we come up with a plan in order to care for that patient so that we provide the highest quality of care. Also, medication administration is very important in the United States. So we have very structured processes in the U.S. related to medications. As an example, drugs that are controlled substances. Two nurses actually have to review the medication, have to review how much you are pulling up in your syringe, and also have to watch when a nurse is wasting the rest of the medication. In the United States, even though the vial might have more medication in it, you're not allowed to put that in your pocket and then dispose of it later. You actually have to do it at the time that you're giving the medication to the patient and what you're wasting. That's something that's very important, and also making sure that we're documenting those things in the electronic medical record. Hello from Jamaica. Infection control, we have a lot of protocols in the U.S. One of those things is personal protective equipment. And what that is in the United States is that, it could be goggles, it could be a mask, it could be a gown, it could be shoe covers. Depending on what type of infections a patient has, there'll be a sign on the door of a patient's room, and it will tell you what sort of personal protective equipment you need to wear prior to coming into the room. In the U.S., we do have a lot of technology that we're using. And some examples of that are electronic health records, or sometimes you might hear them as electronic medical records. And that is where we do all of our clinical documentation. So as far as head to toe assessments that we're doing on patients, we need to make sure that we're documenting that in our electronic medical record. Any sort of concerns that a patient or family bring up to us, we have to make sure that we document that in the electronic medical record. Any sort of vital signs that are not interfaced from like a bedside monitor have to be documented inside our electronic medical record. So basically, what we say in the United States is, if it's not documented, then it hasn't been done. So a good rule of thumb is to over document. Good morning, everyone. Glad to see that we have someone from Ghana and Pakistan. Welcome. Um, and the other aspect is cultural competency. We have a lot of diversity in the United States. We have nurses from every corner of the world. And basically, what we're taught in the United States is that we have to embrace everyone, regardless of their culture, and be respectful of their culture. And when you come to the United States, every single person that works in a healthcare organization goes through cultural diversity training so that we make sure that we're being all inclusive and we're being, true teammates to everyone that's working with us. Good evening, everyone. Next slide, please. And so, what should you really expect, and how should you really adjust your clinical skills in the U.S.? It's a life change when you come to the United States. And what I would recommend is, number one, you're going to be faced with a hospital orientation. The hospital orientation can last for about a week. And in that orientation, they're going to teach you things like what electronic medical record is used, and they'll train you how to actually document in that system. They'll also teach you how to use our IV pumps and how to make sure you're doing the right dosage calculations for those IV pumps. They're also going to teach you about the policies and procedures that are at that hospital. They're going to talk to you about healthcare benefits in the United States. We pay for our healthcare benefits. Our healthcare hospital systems offer us different benefits. And during that orientation, they help us to understand what the differences are and which ones would be best for, yourself or your family. And some of those, all of those come out of your paycheck. So there's a part that the hospital system pays, and then there's also a part that as an employee, I pay out of my paycheck. As far as like the clinical skills, then you're going to go into a preceptor program where you'll be paired with another clinical nurse. Some of the things to know about U.S. Nursing is that we really have many nurse-driven protocols. So they empower us as nurses in the United States to make clinical decisions within certain parameters without having to call a physician and ask a physician of what we should do next. So as an example, if I have a diabetic patient that's on an insulin sliding scale, based on their blood sugars, there's a nurse-driven protocol that is within our electronic medical record that says if the blood sugar is X, this is what I want to titrate my insulin drip up to. And so we have a lot of protocols like that really empowers us as nurses to proactively care for our patients. And then there are times when patients fall out of our nurse-driven protocols that then we escalate things to a physician. Specifically, when there's emergency situations, we're going to definitely escalate that to the physician and other members of our care team. The other thing is that we have patient-centered care. And what that is really meeting the needs and preferences of our patients and also the families. That's something that's very important in the United States. The other aspect is that, as I mentioned before, we do practice team-based care. So if I'm a nurse, there are going to be other team members that are helping to support the care of the patients I'm caring for. Great example of that is if I'm a registered nurse on a med-surg floor and I have 6 patients, I'm also going to have a patient care tech that's going to be working with me, that's helping me care for those patients. And in that, we want to make sure that we give appropriate tasks to that patient care tech. So as an example, patient care techs can take vital signs. They can also turn patients. They can get a patient up to the bathroom. They can bathe a patient. Those are all things that we do in the United States, and we partner together with other team members to make sure that all of that care is given to our patients. The other aspect is communication and coordination. Really important to make sure that you feel like you have a voice, making sure that you can talk to others and be open and honest about what you're seeing with a patient, or if you're having a challenge. We really do in the United States like to support one another from a clinical perspective. There's always a wide variety of different nurses with different levels of experience that are on the clinical units, and we like to be able to support one another. Um, some examples of team-based care. One would be chronic disease management, where we might have a diabetic educator for a diabetic patient. You as a nurse are going to be taking care of them. There'll be an endocrinologist that will also be there. And together we decide what type of care we're going to give them. I think the other thing to mention is that we really have some other aspects of in standards within nursing care in the United States, such as there's an organization called the Joint Commission. The Joint Commission oversees us as hospitals and makes sure that we provide high quality, safe patient care. And every year they come out with they come out with our national patient safety goals. And some of our national patient safety goals this year, and every year they're different. This year it is identifying patients correctly. So in the United States, we're required to have 2 ways that we identify a patient. So one way that you can do that is you can ask the patient their name and date of birth. And that's a great way to make sure that you have the right patient, and you're giving the right medication to that patient by that two verification step. Also, another patient safety goal that we have in the United States is improved staff communication. And what they really look for us to do is that as important test results are posted, making sure that that information gets to the right staff member. So if it's, me as a nurse, that I need to know that the white blood cell count is extremely high, we need to make sure that that information is getting to the right person. Some other things that are very important in the United States is our medication safety. So our patient safety goals for medication safety is that before any procedure, we make sure that we label medications that are not labeled. So if you're in a procedural area like a cath lab or an operating room, if there's any medication or any vial that is on any tray, it has to be labeled before the procedure begins. The other step is that we also want to make sure that we're recording and passing along the right information about any medications that have been given to a patient, and it's clearly documented and communicated to other clinicians. The other aspect is we talked a little bit about infection control, and one of the patient safety goals is preventing infections. And that is, we're focused on hand washing. And so when you come to the United States, every nurse that starts at a healthcare system, whether you're a US nurse or you're an international nurse, they will go through the proper techniques for hand washing in the United States. And they'll watch you and make sure you're doing it the right way when they first teach you. And then they'll answer any questions you might have or redirect you to make sure that you have the proper hand washing techniques. We also identify patient safety risks. So in the United States, we want to make sure that we're identifying any patients that are at risks for like a behavioral health perspective for suicide risks. And we want to make sure that we're screening patients for behavioral health assessments in the United States. And then the last one is preventing mistakes in surgery. So within our operating rooms, we have a timeout procedure that occurs. And what that means is the patient's in the room. Before the surgeon starts the procedure, there is a timeout. In that, we verify the name of the patient, their date of birth, the site of surgery, And we make sure that all of that information is accurate and marked on the patient's body prior to the procedure starting. And just on a side note, the Joint Commission certifies each hospital. So every couple of years, they come into the hospital and they actually watch us as nurses. They go through each clinical unit to see if we're following these national patient safety goals. So when you come here, you'll be educated on them, and they'll show you how to document all of that information into your electronic medical record at the hospital you'd be working at. So I hope that some of that information is valuable. I'd like to kind of turn it over to the chat. And if anyone has any questions for me related to any sort of clinical aspects in the United States.
All right. Yeah. So now we're on the Q&A session, Laura. So first question, how do I adjust to the US shift schedules and workload? Because, for example, in the Philippines, they are working I think 8 hours, and some in the GCC, they're working 7 hours.
Okay, so that's a great question. There are different shifts in different clinical units in the United States. So you might have, in a hospital setting, you're either going to see 8, 10, or 12-hour shifts. And with that, so one of the things with that is if you're working 12-hour shifts, that means you only work 3 days a week. And then you have the opportunity, if you want to pick up overtime. If you're working 10-hour shifts, you'd be working 4 10-hour shifts. And if you're working 8-hour shifts, and this is full-time, if you're a full-time worker, 8-hour shifts, you'd be 5 days a week. Typically, you're going to see that there's a rotation that they have you work every second or third weekend, depending on your clinical unit. There perhaps is an on-call schedule if you're in an area where there are emergencies that come through, like the cath lab or the OR. And what I would say to you is no matter what shift you're working, give yourself an opportunity to adjust to the shift that you're on. So as an example, if you're working night shift, and you're working 7 p.m. to 7 a.m., make sure when you get off at 7 a.m. That you go to bed, you get enough sleep before you come back to work, because in the United States, when we work night shifts, there is no napping or sleeping while we're there on shift. We need to make sure that we're alert and actively taking care of our patients while we're there.
Awesome, great answer. Next question is, what's the process for reporting and handling errors or incidents in U.S. hospitals?
Great question. So whenever there is an error, you're going to notify your immediate manager and let them know of the error. And then there's a documentation that we do within the electronic medical record to list out what the error was. And typically, you should not fear retribution for verbalizing an error, whether it was an error by yourself or you saw someone else have an error, because in the United States, we really have a view that we want to make sure that everyone has a voice with no fear of retaliation. And many times when there's errors that are identified, it's an opportunity to look at the processes that exist in the hospital, and perhaps there needs to be a new process to ensure the error never happens again. So, you just always want to be open and honest and very forthright when you come, and making sure you're bringing it to the attention of your manager immediately.
Okay, awesome. All right, and here's our last question for today. So, how to manage differences in patient expectations and family involvement in care?
So I know for many of you, just from the feedback I've heard from some of our international nurses, some of you maybe haven't had family members that are allowed to be in the room and really be part of the care. One thing to remember in the United States is that you're treating the patient and the family. And what I mean by that is you're going to want to, when a family's in the room, explain why you're doing something, just as much as you're explaining to the patient, and answering all of their questions. It can be hard to adjust how you're speaking to each patient and family, because each patient and family have different expectations of us. But I think the biggest thing to remember is, as long as you are open, and fully listening to the patient and the family, and then really trying to do your best in order to meet the needs of what they're looking for. And if you're not able to meet the needs of what they're looking for, it's okay to explain why you can't. Or perhaps you might have to bring someone else into the room if you're unable to meet a need that the patient or the family has, and just bringing the right resource into the room so that they feel as though they have been heard and they're getting the answers that they need.
Cool. Thanks, Laura. Okay, so that's with our Q&A session, and I'll just want to throw in this links for all of you guys. So like us and follow us and like us on Facebook for immigration updates and new positions. I'll put the link on the chat. So every week we have webinars and updates. You can check those in our Facebook page. And also, if you have a nurse friend, a nurse colleague who wants to start their journey and to work in the United States, please refer them to us. I'll also put that on the chat. So with every successful nurse that you will refer, you will earn up to $250. Okay. Any last thoughts, Laura?
Thank you, everyone. I'm thrilled to be able to share these things about U.S. Nursing. If you ever have any more questions, would love to hear from you. Have a great day, everyone. Or